So, and I know we had this conversation about most people think it's celebrities only, which I know you've worked on a few celebrities as well. Will not mention names, but also the average man, so to speak, right? So it's something that's been upcoming, right?
Yeah.
So I think maybe let's start from the top. What options are available? Because when you're driving around, certainly Nairobi, you see certain billboards, right? There's balloon, there's that. What are the options available first in Kenya? Hello, welcome to the One Health Lens podcast, where we have healthy conversations on matters health, global health, public health, and the road to universal health coverage. I'm your host, Dr. Diana Wangari Gitao. In the studio with us, I have, as always, important guests, where we'll be talking about weight loss, from surgical options to diet. What are the myths? What are the misconceptions? So welcome. Karibu, Daktari, you can introduce yourself.
My name is Dr. Lance Mayabi. Mm-hmm. I'm a general laparoscopic surgeon with a passion for weight loss and healthy living.
Yeah. On my, what side is this? Left. On my left. Yes.
My name is Mika Kibera.
Yeah.
I'm a clinical nutritionist focused on weight loss and healthy living.
Yeah, absolutely. And what's important about Mika is he's a trained. It's important to get this. He's a trained nutritionist with a focus on weight loss. That's true. Yeah. Which many people are not actually. We can give sort of education advice, but he has the actual training. So we have the right guest for you here. I think we'll start off with Dr. Mayabi, because I mean, there's a lot to say. I know there's a lot, and perhaps it's even unfair of me to start off by talking about surgical options, because before we get to surgery, there are many options before then, right? Okay. But maybe let's start with, how did you get into this, right? You are a surgeon. How did you get into this, first of all?
So I trained as a general surgeon at the Aga Khan University. And after I graduated, I actually wanted to go into plastic surgery.
Uh-huh.
So I worked with a plastic surgeon called Dr. Michael Ribeiro. But I think during our interactions with him, I actually noticed that I have a liking to weight loss, because most of the cosmetic procedures you'll do actually they had better outcomes with weight loss. And I realized that I'm already a laparoscopic. I'm able to do laparoscopy. I'm able to do endoscopy. So that was the aha moment. So how do we marry together with the cosmetic side to actually increase the outcome? And that's how I delved into weight loss, or what we call bariatric surgery.
Yeah. What's laparoscopic, endoscopic? Big words.
So endoscopy is the parent word. So it's only minimally invasive surgery, or what we'll call either scarless or small incision surgeries, or what in other places they call it keyhole surgery.
Yeah.
So endoscopy per se, by what many people know about it, is to look inside using a camera. So you can either look inside into your stomach, look inside into your colon, you can look inside into your uterus, you can look inside into your abdomen. Either of those is endoscopy. Now laparoscopy specifically means it's an endoscopic surgery, but this time you're making small incisions into the abdominal wall and using a camera to operate from outside in. The traditional endoscopy is what most people think is to look into your stomach and your colon, where you still use a flexible camera to look into your stomach or colon, but also you can use other natural orifices, your nose, your ears, your urethra, your vagina. All those things are ways where you can operate from outside in, but using a camera. Yes.
I mean, it's interesting, and I know we had this conversation even before we began the recording.
Yeah.
In terms of just your journey as well, how intertwined image is for most people, and how weight loss has become such a central conversation or a factor of just lifestyle, right? It's no longer about just being healthy. It's I must look good as well, right? So, and I know we had this conversation about most people think it's celebrities only, which I know you've worked on a few celebrities as well. Will not mention names, but also the average man, so to speak, right? So it's something that's been upcoming, right?
Yeah.
So I think maybe let's start from the top. What options are available? Because when you're driving around, certainly in Nairobi, you see certain billboards, right? There's balloon, there's that. What are the options available first in Kenya?
I think we have, in Kenya currently we have all the options, but even before we delve into
Options. Yeah.
Because what I've noticed is many times people come thinking there's one silver bullet that will give you and you'll lose it.
Yes.
But weight loss is based on 3 things, and I think that's why we wanted Mika to be here.
Absolutely.
Nutrition takes up to 80% of
Yes.
it, and I think he'll delve into that. There's activity, which incorporates exercise and just your natural, in your day-to-day life, how active are you?
Yeah.
Okay, so we'll, especially people above 25 or so, usually want you to have at least 30 to 40 minutes of exercise 4 to 5 times a week. And not saying that I walk every day, because our bodies are wired. If that's part of your work, walking every day, your body doesn't take that as exercise. But mainly just time that you've set aside to actually get active. But also build your life around activity, meaning avoiding taking lifts, for example. If you work on first floor, second floor, why are you taking a lift? If you're going to the mall, why are you parking just outside? Park a bit far and walk. If you can walk somewhere to do some shopping or what, why take an Uber or a border, yet you can walk there. I know we live in a world of convenience. I mean, most time that's what makes us do that. The other thing is a lot of excuses around why I can't exercise.
Yeah.
You keep saying, I don't have money to go to the gym. I don't have time because I'm too busy commuting or not. But if you look at the amount of time you spend scrolling, you just need to start at least even 10 minutes.
Yeah.
And in a world where everything's just within your reach, you can actually use your phone to do exercises. But thirdly is also quality sleep, not quantity sleep. Quality sleep means you wake up refreshed.
Yeah.
So it's not about the length of sleep, because you can actually sleep for a long time and still wake up very tired. I just say here, what happens is, why do you want quality sleep? You actually burn calories in your deep sleep. And that's why many times when you cover yourself, you tend to uncover yourself at some point in the night. When you're having that deep sleep is when you're burning your calories, what we call the rapid eye movement phase of your sleep. Secondly, and I think Mika will concur with me, you have exercised, or you need your muscles to recover during that sleep. And if your muscles don't recover, then what we usually say is fat burns in the furnace of muscle. So you don't have recovered muscles, you can't build, they can't recover, so you can't burn necessary fat. And for us, what weight loss is not losing a figure, but it's losing unnecessary fat. So sorry to digress, but that is the most important. I think that's where we start when we come to weight loss.
In fact, it's such a good way to respond, because I'm like your patients, I imagine, or most patients you encounter who walk into the room and say, Daktari, I want this. And they've immediately jumped to, their own conclusion. Yet it's progressive, right? There's an assessment that comes before, because it's not me coming and saying, I want surgical this, whatever it is, right?
Or I saw someone had this, so I want to come and have what
Exactly.
That's what usually happens.
Exactly. So there's an assessment, first of all, I'd imagine, right?
Yes. Yeah.
There's an assessment that starts before we even go to weight loss in itself, because I'm imagining, as you're saying, it's diet, it's activity, it's sleep. Yeah. So there's a certain assessment that goes into this. I've walked into a room. What's happening?
So one is to just find out what your goals are. Where are you coming from? So usually, are you just the usual? Are you male or female?
Yeah.
What have you tried before or not tried, and why do you want to lose weight? Secondly, sometimes actually you get referrals from also your colleagues, probably someone who's diabetic, pre-diabetic, is hypertensive, has infertility, has very severe arthritis of the knee, hip or back, and maybe they'll require a knee or hip replacement, or it's impending. And that's why we usually start from and see. So what is your goal? Why have you come? And for some people, it's just because they've actually really tried other things and that are not worked out for them. So the problem is many people will start something but not stick to it. So you'll find people have tried a bit of nutrition here. You'll find I've tried it for 1 week or a few days. And they say, can't,
Miracles after 1 week.
Yes, because the thing is, you see many things on media.
Yes.
But most people who are talking about like these fads about nutrition or some type of exercise, many times have a team behind them. They have a nutritionist, they have people, physiotherapists, they have a whole team, but you're just seeing the outcomes. So it looks glamorous and they love before and after photos, but you never know the in between, what was happening in between. So, and I think Mika will concur, people will talk later.
Yeah.
People, weight doesn't happen overnight.
Yeah.
So people come and say, I want to lose this. Some people say, I have a wedding in August.
I
want to lose 40 kg. In fact, someone
and that's in July.
Someone had told me that. I'm like thinking, that's not possible unless we starve you.
Yeah.
But so the thing is, usually tell you that the long you took weight crept up on you over years. It never just came up one day. Yeah. And it's actually the same thing. You almost need to take time for you to lose that weight and maintain the weight loss. So whatever else we do is just to augment it or increase the rate at which that weight is lost. But you always have to remember, if you did what you did before, it will still creep back.
It will creep back.
So there's no one size fits all. So just coming back to assessment, once you have taken your history, found out what brought you, whether you have comorbidities or any other health issues, then the next thing is we do some lab tests. One, just to screen again and see whether you have a low basal metabolic rate. Okay, that means you're a net store of calories. So whether you do exercise or not, then you tend to just net store. So with this, we're able to know now how do you enhance your basal metabolic rate. Secondly, are you pre-diabetic? Do you have issues with your kidneys, liver? What is your blood level? You can actually have increased weight, but you're malnourished. That's the irony. Yeah, so you actually find that someone actually has a low blood level, has low proteins, and yet you look at them, physically they don't appear. So when someone tell them that you're malnourished, and they look at you and like,
it's like, I need a second opinion.
And that's why the most important thing is you work now with people like Mika. Because now Mika does what are called biometrics, and probably after that is when we send to Mika. And then now I think we'll come back and talk about the options. We usually send to Mika with the tests. He does what is called a biometric. And then we sit with the nutritionist and the client and then tell you, based on what we have, this test and this your weight and everything, these are the options that are available for you and why. Yes.
Okay, I mean, roping in Mika, and it seems you're central to this equation. Central. I mean, as Doc said, that is 80%, right? And I guess you hear a lot, because a lot of people, I think, we started off from a place whereby it was watu kujinyima, right? They're not eating. Then it became, at a certain point, it became all this diets, keto, watermelon, and everyone is jumping based on what they're hearing, right? Yet there's fundamental principles around that. So maybe starting from that, what fundamentally do people need to understand around diet, first of all?
Food is what powers you every day, and it's what you subconsciously repeat every single day. When you wake up in the morning, you know you have to have breakfast, you're going to have lunch, you're going to have dinner. Now, those meals are classified based on time, not based on volume. So you'll see someone saying, I can never eat ugali for breakfast. That's dinner. Why would I eat dinner for breakfast? Then you look at them like, they're classified based on time. So that's number one. To eat food being what powers you every day, you're supposed to consume according to what you're going to do. Now, I've seen there's a bit of work being done around. There's a lot of construction activities. Now, if you take a construction personnel, a technician there, and you look at that stone mason or the person laying there, whatever they're doing, and then you try to eat like them, and you're coming to sit in studio.
The whole day.
Yes. And you want to eat like them. So
surplus has to be stored.
Something has to be stored at the end of the day. Now, the other thing is also look at the question of caloric density. Now, you're surrounded by a lot of outlets.
Yes.
So we have Java, we have so many fast food outlets.
Yes.
Now, the key thing with such outlets is giving you a lot of calories in a compact way. That's why you see most people don't even finish what they're eating. By the time they are halfway done, they're like, I'm full, I need to proceed. Then we have our African culture. You can never leave food on the plate. There's someone starving somewhere who will need that food. So when you see a plate, you have to see the bottom of it. In fact, you're told, return it with its original color.
Exactly.
If the plate was white, return it looking
Yes.
white.
Yeah.
So you wind up over consuming calories rather than quantity. You know, you can take a very small portion of food and take a lot of calories with it. But when all that lands in your system, in you, and it finds someone who's not active according to it, you're supposed to be burning 2,000 calories, you're eating 2,000 calories, but you're actually burning 1,500 to 1,200. Then the body is like, what do you expect me to do? I'm going to store. Yeah, there's no one who knows how to keep stores like the body. It was made to keep stores for the future. Now, the more you store, the more you create what we call inactive weight. What keeps you comfortable in your seat keeps you planted and grounded. Now, the more inactive weight you build up, the more you lose active weight, which is mostly your muscle. So they start shrinking, giving space and stuff. Then until it reaches the critical point whereby now your weight is visible. We can see it.
So all this time it has been accumulating, because from what I'm hearing, your caloric intake and your output should almost balance.
True.
So that then in that case you're maintaining both, you're balancing, right? So you're maintaining, if it's your weight, you're maintaining, right?
True.
So if you have more calories intake than what is being taken out, then it starts converting into inactive. Is that right? And then this inactive is what now over time is accumulating as you're losing muscle, so that then now at a certain point as it accumulates, you start, carry on.
Now, when that inactive weight accumulates to the point of grounding you can't even be active. Something as simple, as an activity like walking up the stairs is enough to knock you out of breath completely. Sleeping becomes an issue because of sleep apnea. Your joints can't take it because we get this a lot. I'm heavy because of my bones. Then you look at someone, you're like, no, you're not. So your bones have a limit. They are what give you structural rigidity.
Yes.
When that structure, when you exceed the amount of pressure the structure can withstand, what happens? It collapses. Arthritis and everything. Now you run out of places to store. So you start having anywhere there's a cavity, there's storage. So you start having cardiovascular issues around the blood vessels, around the heart, around the major organs. All this starts happening, and it's something that accumulates over time. There's something I always start by asking: what is the least weight you have held for the past 5 years? Because that starts us off as the first target.
Okay.
If let's say, for example, this is a hypothetical situation. You come in, you are about 120 kgs, you want to be 80. But the last time you were 80 kgs was 10 years ago. How am I going to achieve that?
Yeah.
So now, and I've also given Alpha a bit of a golden information there at the center. All the weight loss plans start off by creating caloric deficits. Now, you can choose to do it organically or through discipline, whereby you'll really sweat for it.
You're working out and your diet is on point.
And then when you walk out of the, there's a gym here in town, you walk out of here, then you come across all the fast food joints. And that's the day they have these sweet aromas.
And a sale at that point,
favorites.
buy one, get two free.
So that's one of them. Then that's when we come in with Dr. Mayabi with the interventions. So we reduce the size of your stomach to make sure that your intake is reduced. So you can now only sustain a specific volume, which creates for us mechanically the deficit.
I mean, it's such an important point that I'd want even to spend more time on, about the caloric deficit, right? Because I think a lot of a lot of it is knowledge, right? Because it's not, I've seen people who are going on water diets, or they're trying to, they're just on water, right? Which then becomes, okay, fine, they still need to get in some calories. I've seen people go into sweat, I don't know what they call it, but they're trying to get out some water, right? Where then they're confusing either bloating, water retention versus calories as well, right? Which then becomes then fundamentally what it has to be is that, and I'm going back to this point around that, is that fundamentally, and you can correct me, that fundamentally why that is so important is even if you're going to the gym every single day, 7 days a week, right? You can still not lose weight because you have not attained that deficit. Is that correct?
True.
Yeah. And is that the same reason why it might be easy to lose the first kg, but then the second kg, third kg is hard? Because then your body, I'm assuming, then gets used to it, right? So I assume if I'm going to the gym and I'm used to a certain diet, right, I lose maybe X number of kgs, but then your body at a certain point gets used to it, and then you have to up the game. Is that how important the caloric deficit is, or?
So that brings me to
I think I can-
transition assessment.
Oh, I've even jumped ahead of myself here.
So I think he'll talk about it, but I wanted to say, I think one thing that after we do the assessment, and I think when you take to Mika and other weight loss nutritionists, what they do is called a biometric. So we unpack your weight. So we take you like a lorry that has carried some goods. We want to know what's in this lorry and unpack it. So we want to know so the entry point is your weight, and then your basal mass index, the body mass index, sorry, which is a function of your weight versus your height.
Your height.
That's just an entry point. You can be two people, one who's obese or overweight, and then someone who's muscular but the same body mass index. So what we do is we unpack the weight. Usually we use a lot of gadgets, so we'll use a smart scale, which has quite extensive way of unpacking the weight. So you look at your fat density, we look at your water content and its percentage. We'll also look at your protein density, your bone mineral density, and what is your basal metabolic rate. There are a few other things that Mika will look at, I think, with percentages and all function of that, but that helps us to have an entry point, meaning if we find your fat density is high, we want to know now, for every time like Mika assesses you when you do an intervention, want to make sure that at least your fat density is going down, your protein density is either going up or being maintained, because like I said before, fat burns in the furnace of
your muscle.
Yes, and you're not losing your structure, meaning your bone mineral density is not going down. So in short, you're not becoming malnourished by losing weight. And I think in our experience, we have noticed that if we tweak that really well, most clients, like you'd come from a cosmetic point of view, actually don't need another procedure, because you actually shrink down gradually into your structure. Very few will need another procedure, either liposuction or body contouring, other forms of body contouring. And my talk, maybe placebos will hear me after this, but even for them, for those who need any intervention, it's actually easier for them, and the recovery is actually much faster for them. So we actually make their work easier, and also the recovery process for the client actually much better. So, and that's why I told you, like for me, my experience, I said from a plastic surgeon point of view, and we noticed that as working closely with him, all the clients who came for a cosmetic procedure who had actually lost weight before did much better. And even whatever was not as extensive as the ones who are not lost weight before. And also their projections, like, people will come, I want to look like, let me say, Beyonce.
Yes.
That's the last person I know in my generation.
Yeah.
Beyonce. So they want to look like Beyonce. But you look at them and like, okay, fine. But you can't achieve it. But if they lost weight, then probably it will be actually easier for them to get to that if that was their goal. But
biometric
I think,
assessment.
Yes. So we usually use a lot of gadgets. So as part of of what happens in weight loss, we usually want you to at least acquire a smart scale, even on your own. What we do is that will help us to track and see, like, what are your trends over
And a
time.
smart scale connects to your phone
To
and
your phone, yes.
and whatnot.
And
so.
you can share it with us.
Okay.
Yeah, and sometimes depending on the device that you use, then you can even have an app where we can even log in. Once step on that scale and goes to your phone, it can even transmit like to a main one, and we can look at your trends and just discuss it. Secondly is also a smartwatch. Smartwatch does two things: checks how your activity levels, like how many steps you're doing per day, but most importantly, what is your quality of sleep? Because when you're sleeping at night, you'll know when did you have deep sleep, or you're having sleep apnea at night. So was your blood oxygen level going down at night? How many times did you wake up? Sometimes you don't even know that you're waking up at night because you're not breathing well because of the weight. You thought you just woke up tired, but the problem is you just kept not breathing well, and that makes you not have a good sleep at night. So you're never achieving deep sleep, or the deep sleep is actually quite a short period.
Okay, so in the assessment, I know Doc says, Mika, there are extra parameters. What are you looking for in particular? Someone has been sent to you. What are you looking for in particular? And how long does it take to conduct this assessment?
So let me say it's a session. It's a session that can last for up to about 1 hour, because it's an interactive session. I summarized it to, let me call it a metabolic assessment. I want to understand what you've tried, how far you came with it, and what made you stop it. Then after that, as I said, I dive in a bit deeper, get to understand the least weight you held in the past 5 years. That forms our first nini. What is your motivating factor, so that we can differentiate between they're called targeted weight loss or a specific area weight loss, whereby they want to lose tummy alone, and people want to lose their general body weight. It's all about it's more of an educative session to also help someone understand what would be the outcomes of them going down this this route, or picking or whatever we're going to recommend. Then I go for the biometrics. I do composition assessment. I look at your muscle and also do it segmentally, so that I can see what this hand is holding versus what this hand is holding, the torso and the legs. And then I also look at your fat mass and its distribution, and that helps me understand whether you're active or not. There's a lot of things there. So if you find someone with a high fat mass towards the lower bottom of their body and a low muscle mass, that's someone who doesn't work. Or if you find they have normal fat mass bottom to the legs and less muscle mass, that's someone who doesn't rest. So that's where sleep comes in. So this is someone who never rests. They do not have time to repair their muscles.
Wait, when you find what muscle for what is it?
When you look from their waist downwards, your legs are the most active muscles in your body. If you can walk. So whenever you walk, you face two things. You can face either atrophy or hypertrophy. Hypertrophy is what we want. Destroy that muscle, then in the process of resting, the proteins in your system are used to repair them. Atrophy is equivalent to aging. It's muscles losing functionality over time. And also that is what can happen if you starve too much. You get a lot of atrophy. Because let's say you get a bill of about 1 million in your house, hypothetical situation. I don't think it can come to that figure. So you get an electricity bill that is outrageous. What's the first thing you do? Go checking which appliance in your house is consuming the most electricity. You even start doing the physics of voltage, capacitors and stuff. Then you start switching them off. If it is your light bulbs, you switch them off when you're not using them. The body does the same. The minute you limit the amount of energy it's getting, it goes switching off unnecessary muscle activity. So if it can make you not walk, trust me, you won't walk. Because there are things it cannot touch. It cannot touch your heart, it cannot touch your liver, it cannot touch your kidneys, and it can never touch your brain. The brain is
all the other muscles.
All the other physical outside muscles, they are going to shrink. And the minute they shrink, that is going to even affect your mobility. So you see such a person, you can't push them to the gym. They need to first of all lose a bit of weight, get lighter on their feet, then start walking. After they're comfortable with walking, they can now go to the gym and start lifting weights and doing everything. So that's how I assess. And also I look at the visceral factor. Now, visceral is storage around the abdomen.
Yeah.
And there are two types. There's what goes around your spinal cord, cushioning it from impact. We don't want you to lose that one. And then there's what is stored around your organs and also the belly area. That's the one we want you to lose. Now, Doc said something about, actually you're the one who was talking about it. You go to the gym, you exercise, you come back, the weight is not reducing. I always ask one critical question. Have you changed clothes sizes?
No, I haven't.
No, but that's what happens. There's something called positive weight exchange, whereby you lose body fat and you gain muscle. Now,
I've become bigger, by the way. Anyway.
So you lose body fat and gain muscle. The scale never changes, but you find your clothes sizes keep becoming bigger. So whenever you wear your clothes, they dance around. That's another index of progress. And it makes someone understand that your weight is not only what the scale shows. There is so much quality to it. So it gives a lot of insight. Now, there's also the question of functionality. I talked about stairs. It's a good way of assessing someone. Now, we're on a specific floor.
Yes.
And every time you come up to this floor, you get there at the reception and you're panting, sweating. You even have to sit in the reception area and then catch your breath before you can continue with your day. That happens the first time. Then in 4 weeks, you repeat the same activity, and then we monitor that. Another 4 weeks, repeat the same activity, we monitor that, so that it shows us improvement in functionality. Same to sleep. You go to sleep, you keep shocking yourself out of sleep because of apnea. Then over time, you start getting the deep quality sleep. You start even waking up more refreshed and so forth. Functionality. So it's not only about reduction in size. It's also about what are the qualities we are introducing to your life. Same, Doc talked about the question of infertility. You lose weight, then on the first trial, the oven is hot.
It's hot. I tell you.
The oven is occupied.
Yeah.
That's a win. The people come in, and during the process of weight loss, the first few months, they get what we call metabolic balance. The body learns how to differentiate between substrate intake of food and stored fat. So it learns when to burn fat and when to burn food. They get better glucose control. They even get better blood pressure readings. So for such people, when we sit and we have that conversation, we let them see the bigger picture rather than being fixated on the scale and the scale alone.
I mean, Doc, it's I'm picturing myself in this scenario, right? I've had this conversation with Mika, right? But this is going to take time. This conversation with Mika, it's going to take time. I'm hearing I have to monitor for a while certain things. I have, diet and whatnot. And I guess partly it goes back to what you're saying. It's that you want the first intervention to be more diet and lifestyle based, so that even if there's a secondary intervention, whether you do surgery or whatever it is, then you can maintain the weight, right? I understand that, but it takes time. Yet most people, they've seen the pictures you said in your example of Beyonce, or they have a wedding
or even Oprah recently.
Exactly. So quickly, I want fast turnaround time. I mean, it's very hard for me to maintain a diet. Also, I like eating what I like eating, right? Yeah. If it's gym, I go to the gym 4 times a day myself, but partly at a certain point, because of muscle, I was like, no, too much, right? So then I'm imagining you get patients, you've sent them to Mika, you already have an assessment. What next?
So what happens, we get the assessment, then now we go back to the BMI, still as an entry point, and also what are your comorbidities, meaning are you pre-diabetic, are you diabetic, did you come with infertility, are you having joint issues that probably will lead you to need a replacement or not, and what is your mobility? Because I might have told them, like Mika said, to exercise, but they can't. So the only way to make them become active is they need to lose weight, and they need to lose it fast. So what happens is now we go, when you use the body mass index, usually say anyone above between 30 and 35 with no comorbidity, then at that point you usually recommend non-surgical options, which is mainly the balloon.
But what's the breakdown typically of BMI, right? When is it normal? What are the ranges?
So I know 30. Okay, I keep forgetting, but I
Mika.
know for me, it's above 30.
Yes. Yeah.
You should lose weight.
Yes.
But I know the upper limit usually is 18 to 25.
18, 25, yeah.
But between 25 and 30, then you're overweight. Above 30, then you're getting to obese. Above 35, you're now getting to class 1 and class 2, and amongst others.
Okay.
But I think for us, invariably, the entry point is still the BMI.
Yes.
But most, I think sometimes we don't even use the BMI. I think most invariably, just like Mika said, we just assess where you came from, where you are, and where we want to go. Then based on our options, because the options will also let us know how much weight you can lose, the percentage of weight that you can use, then we can know how to guide you. So for example, if I just use a BMI, let me just stick to that.
Yes.
That one usually know. Anyone above between 30 and 35, then we'll do the balloon. Anyone above 35, then usually option for a surgical intervention. But some people come, their BMI is between 30 and 35, but they're either infertile or have infertility issues or things like common in ladies, polycystic ovarian syndrome. They're pre-diabetic during our assessment, or diabetic, or even have high blood pressure, and we want to reverse those things. They're having knee joint issues. What usually advocate for is we now just say what our options are. Okay. Then also look at the goal of the client, and most important also what they can afford. I think sometimes that's also very important.
Yeah.
So the non-surgical one is a balloon. We are proud to say that at least we have all the options available within the country. Most all of them are based on time.
Okay.
So there's a pill balloon that called the Allurion by proprietary, which you swallow, fill it up with some fluid, and then just remove it. The advantage of it is it does not require any form of sedation. So you don't require the endoscopy to place it.
So you just swallow it.
You just swallow it.
Okay.
Use an X-ray to see that it's well placed, fill it up with fluid, and then remove it. Takes about 10 to 15 minutes, and you're done. The only disadvantage of it is it lasts for a shorter time. So it lasts about 16 weeks. And it's usually about 10 to 15% of your body weight. Starting body weight is what is lost over that 16 weeks.
Okay.
So the only other advantage also, it passes on its own once the duration has come. So it just passes through your digestive system. But traditionally we have now the endoscopic one. So there's a six-month one, and there's a 12-month balloon, which we recently introduced. So that just being with the duration, you tend to at least push it a bit more in terms of the weight loss as opposed to the other one. Though with either of them, we have seen clients still achieve tremendous weight loss, because what I've noticed in the first 3 to 4 months is when majority of the weight loss tends to happen. Yeah. But now with the constant follow-up, which is very important, and the constant checking with your biometrics, they're able to tweak things to try to bring up and achieve more weight loss. So the only thing is, depending on how we assess, you tend to lose more the longer it stays.
Yes.
Okay.
So you're
you
better
find
off.
you're almost getting in between surgery and the lesser one. So the people will say, I don't want any cut on me. I don't want to go on a general anesthesia because surgery requires that. So now based on where they started before our assessment, then you say, okay, fine, maybe for you and what your goal are, what your ideal weight should be, then you can start with either, mostly it's usually the 6 month, and then we assess. Some we start on the 12th month, and there's also a room for what we call sequential ballooning, meaning once a balloon's duration is out, we have removed it or it passed out, and you can give it a period of 2 weeks to 1 month, and then reassess and see. I think that usually the nutrition support and see whether they're able to lose more on their own, because the disadvantage of balloon is actually you can regain weight after. And that's
what's the purpose of the balloon? So it's what
so
does it
the balloon occupies up to 60% of your stomach, so it causes restriction, so you feel full for longer and you eat less, so you feel full faster and you stay full for longer. Also causes delayed emptying of your stomach. Okay. But because it's a foreign body, it causes a lot of acidity, can cause nausea and vomiting, so it also helps to form habit. So if you eat past a certain amount, then you tend to feel like vomiting or do vomit or get a lot of acidity. And that what, apart from it just occupying space, you notice that clients who have had it for a long time, they tend to almost know, I can't eat more than this, because it has made them form habit over time.
Okay.
But now the preparation for either surgery or non-surgical is still the same. Still have at least 2-week minimum preparation before, where you put you on a diet. For the balloon specifically, we give you some antacid medication that you'll stay on for the duration. This helps reduce the instance of acidity during the duration of the balloon. Also, just to see, we do not want you to lose weight per se, but as Mika said, during that period, we want to see that your function is actually getting much better. And also, what you have noticed, the longer you are, the longer the preparation, and the better you are prepared, the more weight you lose, and the less side effects. There are some side effects you can get, like the hyperacidity, the nausea and vomiting that's expected and accepted during the first week or so. The people who actually don't have it, or those who have it, is actually very minimal. But if someone came today and told me I want a balloon tomorrow, we can almost know. We'll almost have intolerance. So what we do is we have a period of preparation. Whether you like it or not, you can't come, like your question you said, I've tried. We still tell you, fine, at least give you this time period, minimum 14 days, 10 to 14 days, but usually 14 days. We prepare you and then have the balloon in.
When so for people who regain weight, right? Is it so it's after it has passed or it has been removed? Say I had the 12-month balloon, then it's been removed, right?
Yes.
It's possible then
to regain weight.
And
that is the most and that is why I don't work in I can't work in isolation. Okay. And sometimes even we end up not only working with the nutritionist, sometimes with the physiotherapist, because some people come with already mobility issues, so they help us to do exercises for them or show them exercises they can do at home, or even sometimes in the gym we explain to them with the help of the physiotherapist how to do it. The other thing is there's some clients who already have body image issues, have depression amongst other things, so you also have to find out what is their propensity to regain weight after. Are they on drugs because some of the drugs that you use for depression or other mental issues actually cause you to gain weight and eat a lot. So one option is we tries to, during that process, as you lose weight, your feeling about yourself actually improves. So we get you off those medications completely, so that even once you're off them, you're not going back to regain them. Secondly, is why we follow you up is because there's a transition phase. Everyone's genetics is already different. There are people who will maintain once they have lost, but there are some who will almost, the body feels, oh, I'm finally free. So you'll find like almost, but sometimes actually it's a very short time, and sometimes can actually be more than what they lost. Find it even in weeks, they already gained back, and sometimes even surpassed what they got the first time. And people get frustrated and say, this thing doesn't work.
Yes.
And also, you can actually lose weight on the balloon and gain weight on the balloon. When it's still there.
Well, it's still there.
Yes.
Because then what has happened? Your body has...
So what has happened is there are people who cheat. So they love sweets, bags, chocolates. So snack a bit. Because you can still get hungry on the balloon. You can get hunger pangs. So and that's why the nutritionist really helps you. So that you know when you're having this, how do you differentiate from hunger, thirst, being thirsty or not? Because sometimes it's the same. So many times we actually say when you're feeling hungry, take a hydrate first.
Yes.
Hydrate and then see. Even if you're not on any program, when the first instance of your feeling hungry, or I'm saying I'm feeling tired or anything, first thing, hydrate. If you're still feeling the same feeling, then you're most likely hungry. Okay. And that's when people now cheat, because that feeling, am I having a hunger pang? Let me eat a sweet here or not. And the same thing also applies to surgery, because surgery, yes, it may take longer for you to regain weight, but if you cheat with sweets now, and that's usually a problem now in the Middle Eastern countries, because most of their desserts are very sweet. The kulfis and all those things, they're actually calorie dense. So you try and tell them to avoid such things. So that's the non-surgical. When it comes to surgical, currently the most common within our country is laparoscopic sleeve gastrectomy and laparoscopic gastric bypass. Those are the most common. We are hoping that probably in the future we're able to also introduce the endoscopic sleeve. This one will actually be scarlet, so you can. But let me first explain what sleeve is.
What they are. Yeah.
So a sleeve gastrectomy is you reduce the size of the stomach. So you remove 70 to 80% of the stomach.
Okay.
essentially turning it into from a bean shape to a banana shape. You understand? So that does two things. One, you have cause restriction, so it's like having almost like a permanent balloon. But the bigger part of the stomach is also has the hormone that causes you to want to eat, and that is removed. So most people, when you do the sleeve gastrectomy, actually don't feel hungry. They don't feel hungry. Yes. In fact, you're the one keep having to remind them. Even the nutrition regime, you have to keep hydrating. You have to eat, because many times they just actually don't feel hungry. So that's one. Those are the two ways it helps to reduce the advantage of that as opposed to the balloon. But we're just coming back to the balloon. So usually the 6 to 8 month one, you lose between up to 15 to something up to 20%, and the 1 year one, you lose between 20s. You've done well, something up to 30% of your starting body weight. But now the sleeve takes you between 35 to around 50. You can actually go to half your body weight on it. The only thing is, the advantage of it is you lose it more gradual, but a bit more faster than the balloon. The side effects of the same is what we go, mainly because you're cutting off the stomach, then you can have leaks. But that is actually very rare, because the equipment that you use these days is actually quite good. So that's actually a rare complication. You can get bleeding and sometimes injury to the organs around it. And that's why there's that preparation phase, mainly just to reduce the fat around the major organs. But also there's something called dumping syndrome. Dumping syndrome happens when the food comes into your stomach and passes out too fast because the space has actually been reduced. So you get a bit of dizziness, flushing, sweating, weakness. But it is actually very rare when it comes to the sleeve. Now we have the gastric bypass. The gastric bypass is you reduce the stomach size, but also bypass a large part of your small intestine. So invariably you're reducing the size that you can of portions you can take, but you're also causing malabsorption. Now the problem with this is well you lose weight fastest. But now you have the hanging skin. There are more instances of the dumping syndrome. But most important, and this is actually the biggest thing that comes to a nutritionist, is you'll need supplementation for life, unless you for some reason you're able to reverse the bypass. This is because of the malabsorption, and because that helps your body to absorb the essential vitamins and minerals that it requires. So I tend to put, if you look at the studies right now, at around 6 months to 1 year, you look at someone who did a bypass and someone who did a sleeve, then most times they're almost the same. The only difference is with the bypass. Sometimes if you want to, it's usually used for people who want to reverse things like diabetes much faster, and you want to actually do it much better. But I think in our experience, a sleeve well done and with good nutrition support from the physicians and the diabetologists amongst others, then for them we have had instances where I think all the ones that we have had are actually 100% a reversal of their diabetes just on a sleeve. So we tend to put the bypass for a select group of people. I think in our population we don't have the really super obese who might
require the bypass.
Though it's still being done by some people. So you'll find it's actually a generational thing. You'll find the older surgeons who did bariatrics swear by the bypass. As I think we have seen the complications of them, especially the hair falling off, nails, dryness, sometimes partial blindness, amongst other things, bone weaknesses because you're not absorbing.
You're not getting your minerals,
and we tend to go back to the sleeve. The next thing is, what you have to remember is, even for the people who are insured, one, they are not covered by insurance.
Yes.
Two, nutrition is not covered by insurance. Three, supplements are not covered by insurance. So you can think of the bigger cost down the line when even you are choosing. That's how we look at it sometimes, to be honest, cost becomes a factor. We want to get you here, but you have to be cognizant that it is still deemed as cosmetic in our setting, though it's not a cosmetic thing. It's actually a health issue, as opposed to a cosmetic, me wanting to change how I look to look like in a certain way. And
what's ballpark figures of the sleeve versus the bypass and the balloons? What are the ballpark figures? So if
on average, they'll run between, I'll say on average for balloon, run anywhere from between 400,000 to around 500, 550, depending on the center you get it from.
yes,
But let me say on average about 400,000. But it also depends with whom you're getting it with. Some people will just have it to insert, other people will have it as a whole program, including nutritionist follow-up and removal. So it just depends. But invariably it's around that. When it comes to the sleeve, also depending on who's doing it and where, anywhere between 750 to around 850,000. Some people have upwards of 1 million and beyond. But mainly just by how much the provider is providing, where it's being done, and the cost of equipment. So I think, like for us, we may usually try and reduce it and make, hopefully the client can get the equipment at the cost, not having to have a markup on it, so that we're able to reduce the cost down, because that's actually the major cost when it comes to that. We're envisioning to actually bring it down and make it almost affordable to the other countries. People usually leave the country to go to Turkey or Egypt, mainly because it's quite cheap. But the problem is the follow-up is not there. So, but because of them, the equipment is zero rated. So they're able to offer those lower rates, and it's almost like, you can see, they actually make it like an experience. You're going the hotel room, ticketing, all those things. But we usually tell them, even us, we can do that. We can. We bring down the cost. I think we have better things to attract ourselves. We have a better coastal region. We have, even in Nairobi, we have a national park. So if I can say do it in Nairobi, and part of the package can be, you can see Nairobi. Well, I'm actually thinking, looking at where Kenya is at this moment, type of expertise we have. I think we still are a medical tourist site. If you can look like most East African countries, we still get clients from within, and even all the way from West Africa. My thoughts are, if we're able to tap it, mainly just reduce the cost of mainly the equipment, even the medication, almost zero rate it, or having them tax free. Because I know several surgeons were able to do it. Both plastic surgeons were really good, even can do the cosmetic part. Like us, weight loss surgeons who are really good and can do the bariatric surgery part. We have aesthetic nursing practitioners who are able to follow up. We have nutritionists like Mika who are available. So I think in terms of policy, going forward, because this has really affected us, and I know for us, we are a net import of all our implants. We rarely have any money. Even the companies that have it here just import them and sell them within. Then you're able to have almost a zero rate regime. Because you see, like for us, without the dollar fluctuated this year, it affected us a lot, because we were thinking, we can probably get down. Then suddenly you're told by your supplier, you're given notice that we are taking up our equipment. Then you're thinking, some few people who wanted this but can't access it, and sometimes might even find it cheaper to leave the country. And you're like, okay, fine, I assessed you, but to be honest, I can't offer it based on the equipment here. And also because, let me say 99.9% of insurances will not cover it because it's deemed a cosmetic. But if you look at the studies, Actually, if you had a client who was going to need a knee replacement, for instance, which on average will cost about 600 to 750, it's almost, they'll need one and probably need another one. So if they were your client, you're going to spend actually more on them in the near future than if you changed it. Secondly, if they were diabetic and probably, God forbid, they needed a the kidneys had issues and needed let me not say even a transplant, just dialysis. Those sessions, if you look at them in 1 year, you've actually spent more on them than if you help this guy to reverse his diabetes and avoid being on dialysis and probably even need a transplant later on. But I think many times you look at the insurances, look at things, in my opinion, I don't work with them, so let me not throw stones. They probably look at the bigger cost initially. Instead of looking at it, if this is going to be a client for years, am I going to spend down down the line more by having them on or not?
I mean, it's an interesting conversation, and the more you speak, the more I think we need a follow-up, whereby then we're also looking at it from a deep dive into the medical, because then even as I started this conversation, I came in directly as a cosmetic approach, right? Yet there is a medical side to it, right? There are people who this actually, as you're saying, would be able to reverse certain metabolic conditions that they might have, right? Improve quality of life and whatnot. So there's
even
a
just
lot.
think about it. Let's even leave diabetes and all that. Think about how much it costs to do, for example, an IVF.
Yes.
Vis-a-vis, we have had clients who had done 2 or 3 IVFs.
Yes.
They were sent to us for weight loss, and then to have to go back for an IVF. They actually got pregnant after weight loss on the 3rd month. So they spent less.
Yes, exactly.
Spent less grief, because you're always trying and then crossing your fingers. So that's how I look at it. Because they'll have spent more all those times they traveled around, tried here, left the country, came back.
Yes.
But when we helped them to lose their weight and were able to get a baby, even they were asking, why did we go and spend all this time and be, you have to come when it's ovulating, such a stressful time. When ovulating, please come, then do.
It's a lot. I mean, looking at time as well. I mean, I wanted to have even a conversation on drug weight loss as well, right? And even that, because I have a whole list of questions around that, right? Which means then, gentlemen, you'll have to come back. Hopefully. You'll have to, because it's so central to everyday life, right? It's so interconnected that it's not worth just having it as it is me wanting to look good type of conversation, right? It's also, I think, our responsibility to make people understand why they're not losing weight, or why it's also not important to be in a rush. Because important to all this is not so much the intervention, whether you do surgery, whether even you go on a diet, whether you're exercising, it's you being able to maintain it. That's the key. And most people feel at that hurdle, right? They are not able to maintain it, So I will say thank you for coming. But you have an invite very soon to come back again. Please. Again, because it is our duty. It's not just about listening to what the marketers are saying. There is a science behind it. There is long-term implications as well. Thank you so much for joining the One Health Lens podcast. Join us next time. Thank you.
Thank you.